Okay, can you see that?
Yes, thank you.
Okay, so hi everybody. As Belle said, I'm Shivani. I'm one of the consultants at RBH, and I'm going to talk to you about multiple pregnancy today. So obviously multiple pregnancy includes any pregnancy in which there's more than one baby in the womb. The vast majority of these are twin pregnancies, and the majority of twin pregnancies are either MCDA or DCDA twin pregnancies. So I'm going to mainly focus on them just because it's a really vast topic otherwise. Twin pregnancies are really common. In the UK, the rate of twin pregnancies is 1 in 65. So that means that regardless of where you're working, you should definitely come across patients who are pregnant with twins, because they do present to all units and they do deliver in all of the units. 2/3 of twins are dizygotic, so they're not genetically identical. And that rate varies with maternal age, race, nutrition, geography. So it's a very sort of variable rate across the world. And 1/3 of twins are monozygotic, and that rate is fairly constant worldwide. Fortunately, most patients who have twin pregnancies do very well, and their babies are absolutely fine. But they are high-risk pregnancies. There's increased perinatal mortality rates, increased rates of cerebral palsy compared to singleton pregnancies. And that's partly because twins have a higher rate of preterm delivery, and they're often a bit smaller at birth. So we do need to monitor these patients very closely throughout their pregnancies. There's various risk factors for having twin pregnancies. A more advanced maternal age is more commonly associated with twin pregnancies, and that's independent of having assisted reproduction. So even people who become pregnant spontaneously, they're more likely to have twins if they're in their late 30s, early 40s compared to younger. Any sort of fertility treatments can increase the rate of twin pregnancies. So, for example, patients who have polycystic ovaries often have ovulation induction, where they take medication to make their ovaries release eggs. That can be associated with the release of more than one egg and an increased rate of twin pregnancies. And IVF as well, of course. Many patients who have IVF have more than one embryo put back. But actually, even patients who have a single embryo transfer, they're still more likely to end up with a twin pregnancy. And there's various sort of theories as to why that is. And a personal or family history of dizygotic twins is associated with an increased chance of recurrence. And a lot of the time we don't really understand exactly why these things happen. There's various theories, like if you've released more than one egg before, you're more likely to do it again. But these are the things which are sort of more commonly associated with twin pregnancies. So broadly speaking, twin pregnancies can be divided into being dizygotic, in which they're not genetically identical, or monozygotic, in which they are. And this diagram just shows how these twins are formed. So dizygotic twins are formed by two separate eggs being fertilized by two separate sperms. Two separate babies are formed, and they both happen to live in the same womb. Monozygotic twins occur when a single embryo is formed, so a single egg is fertilized by a single sperm. For the vast majority of people, that would lead to a singleton pregnancy. But for some folk, the embryo will split at some point early on in that process, and they will form a twin pregnancy. And these pregnancies can either be dichorionic or monochorionic, depending at what stage the splitting process happens. So I'm not much of an embryologist, but this kind of explains to you how if the embryo splits at a very early stage, they're more likely to form dichorionic twin pregnancies with two separate placentas and sacs. And if the embryo splits later on, it's more likely to be monochorionic. And somebody once said that it's a good analogy is like it's like divorce or the breakup of any relationship. The earlier on you do it, the kind of better it is, essentially, and less complicated it is. So if you've been dating someone for a few weeks and then you split up, it's unlikely that you're going to have, shared assets or anything like that. Whereas if you've been married for decades and decades and you've got a mortgage together, kids together, then the separation process is going to be more complicated. And monochorionic twins are, generally speaking, a bit more complex than dichorionic twins in terms of how they're managed. And very rarely, if the splitting process happens later on during the embryogenesis at day 13 to 15, you can end up with conjoined twins. So in terms of how we describe different types of twins, it can either be in terms of zygosity, which describes the genetic makeup of twins. Monozygotic twins are when a single embryo splits into two, as I said, and dizygotic is when there's two separate zygotes formed. And that's the commoner type of twins. The parents are normally most interested in whether their babies are going to be genetically identical or not. As obstetricians, we are more interested in what the chorionicity is. How many placentas do these babies have? Are they monochorionic, in which they share a single placenta, or are they dichorionic, in which there are two separate placentas? And we also need to assess the amnionicity. So how many amniotic sacs are there? Is it a monoamniotic twin pregnancy, in which both babies are within the same sac? Or is it diamniotic, in which there are two separate sacs? Sometimes you can't always tell for definite if the twins are going to be genetically identical or not. If you have monochorionic twins and they're sharing a placenta, then those babies are going to be monozygotic. They're all genetically identical. Dizygotic twins are always dichorionic. But if I go back a couple of slides, you can see that, well, this slide actually, some dichorionic twins are going to be genetically identical because it occurs when the single embryo splits at an early stage. So if you have dichorionic twins, the vast majority of them are dizygotic, but some of them will be monozygotic. They will be genetically identical. And actually, that's not something that we can tell on the scan. I mean, if they've got separate genders, if you've got boy-girl twins, then you know that they're dizygotic. But other than that, with dichorionic twins, you can't 100% tell the parents that they are dizygotic twins. Most of them will be. There is a sort of school of thought that this is maybe not quite as binary as we once thought it was. Although monozygotic twins are, generally speaking, genetically identical, there are lots of case reports where we have monochorionic twins that have separate abnormalities or different genetic conditions. And there's, again, various genetic theories why that might be. Even with chorionicity and amnionicity, there are sort of case reports about there being a kind of spectrum where the placenta is dichorionic on one side and mono on the other side. But for the purposes of counselling the patients and how we manage these patients, we do sort of treat them as separate entities, dichorionic and monochorionic twins. So the first way in which multiple pregnancies differ from singleton pregnancies is when it comes to screening. So everybody obviously should be going for their dating scan when they're 11 to 14 weeks. And at that point, the baby will be measured and they will be given a due date. And normally, we would adjust the due date to whatever that CRL, crown rump length measurement is. So if patients should know sort of approximately how pregnant they are from their LMP dates, but we normally, for a lot of people, their due dates will change a little bit once we measure the baby. Or we can use the embryo transfer date if they've had IVF. And dating in this manner is considered to be accurate when the CRL is 45 to 84 millimeters. So everybody should come for their scan when they're about 12, it's called the 12-week scan, but really any time between 11 and 14 weeks. And we date their pregnancy, we measure the nuchal translucency and offer chromosomal aneuploidy screening if the parents want it. You can screen for major abnormalities and check for multiple pregnancy and establish what type of twin pregnancy it is. And if somebody is pregnant with twins, this is the best time to work out what type of twins they're having. So if you're scanning somebody and you see that there's two babies there, how do we work out what type of twins they are? There's a number of techniques that you can use. You can look at the number of placental masses, and the first diagram shows an anterior and a posterior placenta. So that's two separate placentas, dichorionic twins. What's generally considered to be the kind of gold standard way of determining what type of twins you have is by identifying the lambda or the T sign. So that's when you look at the sort of joining of the membrane to the placenta. For a lot of twin pregnancies, even dichorionic twin pregnancies, the placentas will kind of be beside each other. Sometimes you will have totally separate placentas, but a lot of them it will just look like one continuous mass. However, when you look at where the membrane is inserting into the placenta, this looks like a lambda sign, and that's got some chorionic tissue in the middle of it. So that's a dichorionic placenta. Whereas if you look at this particular pregnancy, it's a very thin membrane, and there's no chorionic tissue inside there. So this is what we call the T sign, and that indicates a monochorionic placenta. We also can look at the thickness of the amniotic membrane. So this is a very thin amniotic membrane. This is a bit thicker. And sometimes, even though most people find out the gender at the 20-week scan, depending on the position of the babies and the body habitus of the mum, sometimes you can see the genders a bit earlier on. And if you can see different genders, then you know that it's definitely dichorionic twins. So we need to decide which twin is going to be which for the purposes of scanning. And it's important that you do sort of identify both twins separately, because these patients are going to have lots of scans throughout their pregnancy. We need to monitor the growth through scanning, and if we get them confused, then that can lead to confusion with taking measurements. So it's actually quite difficult to do sometimes. It's important to be as specific as you can. The Twins Trust does suggest naming the twins as being right and left or top and bottom, depending on their position in the womb. For some people, if they've got separate placentas, then you can say, well, twin A is the one with the anterior placenta, twin B with the posterior. If they're separate genders, you can make a note of that as well. But it's important that you decide which twin is going to be labelled as the first twin for the purposes of the scans and which one is going to be the second one, although we don't always get it right, and it's not uncommon that there will be a bit of confusion when it comes to scanning these folk. But labelling these babies doesn't necessarily predict which baby will come out first, especially if they're going to be delivering by cesarean section for whatever reason. So that's something to bear in mind when somebody comes in labour, or if they're delivering and there's an abnormality affecting one of the twins, just because the scans have been saying, oh, twin one is the first twin, or twin one is the one with whatever the abnormality is. It doesn't always mean that that's going to be the one that comes first, and you will need to often, especially if they're going into labour or they're having an induction, then you would normally scan them to see which twin is the presenting twin. So in terms of deciding on the due dates of the pregnancy, if you had a singleton pregnancy, you would just measure the baby from top to bottom, put the measurement into the software, and that tells you this baby is X number of weeks and this is what the due date is. It's quite common that twins will be slightly different sizes to each other. And what we normally suggest doing is using the CRL of the biggest twin, and that avoids inaccurate dating due to measuring a baby with any early pathology. And then the next sort of issue is screening. The majority of dichorionic twins are they're not genetically identical, so they are discordant for chromosomal abnormalities or structural abnormalities. That theoretically, monozygotic, monochorionic, genetically identical twins should have the same abnormality in both twins, but sometimes there can be differences between them, probably because of genetic mosaicism and various other genetic phenomena. So the screening test that everybody gets offered at their 12-week scan, not everybody chooses to take it, but everybody would be offered screening for Down syndrome, Edwards and Patals with the combined screening test. And the way we do that is measuring the nuchal translucency, the thickness of the skin behind the baby's neck, taking some bloods from the mum for PAPA and HCG, and looking at the maternal age, and all of these factors are kind of combined to generate an estimated risk of the baby being affected by a chromosomal abnormality. We can do this test in multiple pregnancies, but there are slightly higher false positive rates in twins compared to singleton pregnancies, particularly with monochorionic twins, because the slightly higher nuchal translucency might be an early indication of a monochorionic complication. So for dichorionic twins, you would measure the nuchal translucency of both babies, and you would calculate a risk for each twin, because theoretically they should be separate to each other genetically. Of course, that's not always going to be the case, because a minority of them will have come from the same embryo, but you don't have any way of knowing that. So you calculate a risk for each twin. Each twin will be given a different risk. And for a monochorionic twin, you calculate the risk for the whole pregnancy, and you normally use the average nuchal translucency to generate that risk. If somebody books a bit later, if they're booked after 14 weeks, and the CRL is more than 84 millimeters, then they would be offered the quadruple screening test as well, or instead rather, and that's not quite as accurate, both in singletons and in twins. Lots of people these days go for non-invasive prenatal testing. So this is a blood test that patients can have, and it looks for extra amounts of chromosome 21, 13, and 18. And it's considered to be a more accurate screening test compared to the combined screening test. A lot of people go for it privately, but it is now being offered on the NHS as well for patients who are at higher risk of chromosomal problems based on their combined test. It's not been as well studied, basically, with twin pregnancies compared to singleton pregnancies. It should have a similar performance in monochorionic twins because the babies are genetically identical. With dichorionic twins, they don't often release an equal amount of free fetal DNA, so there's a higher risk of a false negative test, basically, if you're doing NIPT for twins, particularly dichorionic twins compared to singleton or monochorionic twins. It doesn't mean it can't be done. Lots of people still do it with a twin pregnancy. It's just something to kind of bear in mind, basically, and also obviously counsel the patients about. If patients do have a positive NIPT, if they have this blood test and it suggests that there's a high chance of Down syndrome, or if they have their combined test, which suggests an increased risk, then there's some quite difficult decisions for these folk to make. If somebody has a singleton pregnancy and they're at an increased risk of Down syndrome, for example, they would be offered an invasive procedure, and if that confirms, that's a diagnostic test where we take some genetic tissue from the placenta or from the water. And if that confirms that there's Down syndrome, then the patients might opt to have a termination, which is quite it's not easy, of course, but it's a fairly straightforward procedure for a singleton pregnancy. However, if somebody chooses to have an invasive procedure for a multiple pregnancy, there are, of course, risks attached to invasive procedures. There's a risk of miscarriage or preterm delivery, and particularly with discordant abnormality, the parents have to kind of balance the risks that are going to be posed to the healthy fetus by doing this type of tests as well. They can end up losing the whole pregnancy. And if they do decide that they want to end one of the pregnancies, we can't sort of empty out the womb. They would stop the heartbeat of the baby that is affected, but the baby would stay inside, and that can, for some patients, pose risks to the healthy fetus as well. So these are difficult decisions for the patients to make. The procedures are more technically complex as well, particularly with dichorionic twins. You would need to put a needle into each sac to collect genetic material from each baby. In this neck of the woods, we would normally refer the patients to Oxford for that, for the counselling and for any invasive procedures or selective reduction procedures. So these patients are, as I said, they are more high risk compared to singleton pregnancies, and they should be coming to the consultant-led clinic, where you may end up seeing them if you're covering clinic, Some places have sort of specialist twin clinics, and for some places the patients just kind of get divided up fairly equally amongst the different consultants. But there are various risks which are a bit higher compared to singleton pregnancies, and we have to discuss them with the patients and take appropriate precautions. So anemia is obviously very common in pregnancy, and there's a higher incidence of anemia compared to singleton pregnancies. So the NICE guidelines for multiple pregnancy suggest that in addition to doing the blood count at 12 and 28 weeks, we should also check it a little bit early at 20 to 24 weeks. So if the patients are anemic, then they can be given appropriate supplementation. They should be given the same sort of dietary advice compared to those with singleton pregnancies. And in addition to the risk of anemia being higher, you also have to be mindful of the higher risk of PPH when it comes to delivery with twin pregnancies, because the womb is more distended with two babies being in there. So you want to make sure that you've got their blood count as good as possible before they deliver. Also, being anemic itself is a higher risk factor for having a PPH. There's an increased risk of preterm birth. The NICE guidelines say that it's about a 60% risk that twins will deliver spontaneously before 37 weeks, and that's probably because the womb is more stretched out with them, with there being two babies in there, and that can sometimes provoke preterm labor. The risk might be even higher if they have other risk factors for preterm birth as well. Obviously, if the babies do deliver early, that can be associated with consequences in the long term for the babies. And even if these babies we'll come on to delivery planning a little bit later, but even if twins don't deliver preterm, we normally deliver them at 36 or 37 weeks, depending on what type of twins they are. And there are, even though that is generally considered to be term after 37 weeks, and most babies will be fine, there are some risks of early term birth as well, higher risk of neonatal admission, educational attainment in the long term, and things like that. So, normally it's just a case of us warning the patients they're at an increased risk of preterm birth. Don't hesitate to give us a call, contact the triage department if they think they're going into labor. There aren't any specific recommendations about giving patients cyclogest, which is progesterone pessaries, which are often used for other patients who are at an increased risk of preterm birth. There's no particular indication for routine interventions like bed rest, Arabin pessaries, cerclage, topolytics. So these are all things which can sometimes be considered for other patients who are at increased risk of preterm delivery. Again, whether or not you do cervical length scans will probably depend on where you're working. It's not part of the national guidelines. We don't do it at RBH, but I think, there's hospitals I've worked in the past do offer cervical length scans for these patients. So that will probably depend on local policy. If somebody is going into if somebody's in preterm labor, or if you think that it's likely that they're going to deliver early, then targeted steroids will be useful for them. Obviously, steroids are most beneficial for the babies when they're given within a week of delivery. Which can be difficult to know. Sometimes people come in with threatened preterm labor and then it all settles down. Or we think that folk might need to be delivered iatrogenically and then they sort of get better. But if possible, you should aim to give the steroids in a targeted manner for patients who you think are realistically going to be delivering early. There's no role for untargeted or routine steroids. So I think in the past, some people used to just give all the twin patients steroids at a certain gestation. That's not something that we would recommend at the moment. So a twin pregnancy is a risk factor for developing PIH or PET, and it is included in the sort of NICE protocol about which patients are at an increased risk. Patients who have one high risk factor or two moderate risk factors should be recommended to take aspirin, 150 milligrams at night, from 12 to 36 weeks, and that will reduce the risk of developing preeclampsia. So it's important that you bear this in mind and include that in your kind of calculation of what the patient's risk factors are. Not everybody with a multiple pregnancy will necessarily need to take aspirin, but if it's their first baby or the patient's overweight, or if she has any of the other moderate risk factors, then you should make sure that she has been recommended to take aspirin, as it will reduce her risk of developing preeclampsia. And of course, we would just screen for it in the usual way, regular blood pressure and urine checks throughout the antenatal period. And it's normally a good idea to just warn patients of the symptoms of preeclampsia, so that if they do develop it in between their appointments, they know the sort of things to look out for, the things which should trigger an additional blood pressure and urine check. Again, multiple pregnancy is considered to be a risk factor for VTE. Depending on what paper you look at, the adjusted odds ratio is 1.7 to 4.2. It is included as a risk factor in the Green Top guidelines, and a lot of hospitals will sort of make their own policy about VTE prophylaxis, which will normally be probably quite similar to the Green Top guidelines. So you just need to make sure that you include it in your risk assessment of these patients. The sort of normal thing is if somebody's got more than 3 risk factors, they take VTE prophylaxis from 28 weeks. And if they have more than 4 risk factors, they should take it from booking. But I mean, it will just depend on local policy. So you just need to make sure that you bear that in mind. Feel free to add questions to the chat box. I'll just go through the presentation first, and then we can have a discussion afterwards. And then these patients should get additional scans. So DCDA twin pregnancies, I mean, everybody should get their 12 and their 20-week scans. For DCDA twin pregnancies, they should have scans every 4 weeks, normally from 24 weeks. And MCDA pregnancies, they should have scans every couple of weeks from 16 weeks. And there's a number of reasons why we recommend extra scans for these patients. The SFH measurements, symphysiofundal height, is not going to be as accurate if you have a twin pregnancy on board. So obviously for a low-risk singleton pregnancy, the midwife would be measuring the bump and referring for scans if she was worried, but you can't really do that with a twin pregnancy. Twin pregnancies are generally considered to be a bit more high risk with increased perinatal loss rates. So we should, for any high risk patient, we normally like to do some additional scans to identify any problems at an early stage. There is an increased risk of preterm birth. So every time the patient comes for a scan, there will be an estimation of the baby's weight. And if they do happen to come in labor, then at least we've had a recent scan giving us an idea of what the size of the babies are. It's very useful to know the position of the babies for delivery planning, although it is important to remember that sometimes the baby that has been kind of labelled as the first twin might not be the one that comes out first. That will need to be assessed at the time of birth. And in monochorionic twins, we need to look out for any monochorionic specific complications, which we'll have a quick chat about as well. So I'm not going to go into too much detail about these because they are quite specialised. They would normally, if we do identify any of these issues, they normally get referred to Oxford and sometimes on to London as well for management. And they're quite uncommon, so I'm not going to go into too much detail about them. But basically, monochorionic twins are considered to be more high risk compared to dichorionic twins because they're sharing a placenta, and there's lots of connections within the placenta. So the placenta is kind of like, you know, the kitchen for the baby, basically. That's where it's going to get its nutrients, its oxygen from. And I'm sure if you've ever shared a kitchen with somebody else, living with folk or, you know, housemates at uni or siblings, you'd probably know that the food in the kitchen doesn't always get divided up 50-50. It's not uncommon for one baby to take more than their fair share. And because there are all these connections in the placenta between the two babies, it's possible for one baby to essentially steal from the other. So you can get twin-to-twin transfusion syndrome because of arteriovenous anastomosis, and that can cause a hemodynamic imbalance between the babies. You can get twin anemia polycythemia sequence, and that's when red blood cells sort of go in one direction from one baby to the other. So you get one baby that's sort of donating blood to the other and it becomes anemic, and the other baby becomes very polycythemic because it's got too much blood. You can get TRAP sequence, twin reverse arterial perfusion, when there's a large arterial to arterial anastomosis, and there's a pump twin, which is sort of sending blood to an acardiac twin, which isn't really a twin at all. It's just like a sort of extra bit of tissue, which is kind of taking all of this nutrition from the healthy baby. Or you can get selective growth restriction, in which there is a big growth discrepancy between both babies, probably because of unequal placental sharing. Most of the time, these patients won't have any symptoms when they have these sorts of complications. Sometimes with TTTS, they might notice that their bump becomes very big because one baby gets lots of polyhydramnios, but that's quite non-specific. Their bump is going to get big anyway. So the only way that we have of really knowing if any of these complications are developing is by doing regular scans, and that's why we scan patients fortnightly from 16 weeks onwards if they have monochorionic twins. And then as the patients are coming towards the end of their pregnancy, assuming they haven't gone into preterm labor prior to, before the end, then we need to plan their birth. So one important thing that we have to discuss with the patients is the timing of delivery. For DCDA twins, we normally plan their birth from 37 weeks because there's an increased risk of fetal death beyond 38 weeks. And for MCDA twins, we normally recommend delivery from 36 weeks because there's an increased risk of fetal death from 37 weeks. And you can see from this graph, which was published in the American Journal of Obs and Gynae a few years ago, how if you're doing expectant management, if you don't deliver these twins and you get towards term, the rate of death massively increases. So we should be delivering these babies a little bit earlier compared to a singleton pregnancy, where we're normally quite happy to wait till 40 weeks or even beyond 40 weeks. The NICE guidelines do say for MCDA twins, if you're considering delivery at around 36 weeks, you should consider giving them a course of steroids. And it depends on the mode of delivery as well. For some people, they'll need to deliver by cesarean section, or they will choose to deliver by cesarean section because of the risks associated with vaginal birth. And we generally have a low threshold for giving steroids to patients who are delivering by elective cesarean prior to 39 weeks because of the increased risk of breathing difficulties for the babies. Of course, in this day and age, we can't really sort of tell anybody what to do. We can only offer a delivery, and some people don't want to be delivered early. So if that's the case, they should have weekly appointments with an obstetrician and weekly scans to monitor the growth and the Dopplers of the babies. In terms of the mode of delivery, vaginal birth is a safe option to deliver twins. If twin one is cephalic, if the presenting twin is in a head down position, if there's no significant size discordance, if there's no obstetric contraindication to labor, if the baby's more than 32 weeks. And however, it's important to be aware and to warn the patient as well, even if they are planning a vaginal birth, a third of them will end up delivering by cesarean section. And there's a very small risk of cesarean for the second twin after vaginal birth of the first baby, either if the second baby goes into a funny position or if the baby gets stressed. Cesarean sections are advisable if the patients come in and establish preterm labor beyond 26 weeks gestation and the first twin is not in a cephalic presentation, or beyond that stage if even at term, if the first baby is not in a cephalic presentation, then we would be recommending delivery by cesarean section for these twins. And NICE says that it should be an individualized decision before 26 weeks, because obviously there are risks to doing a cesarean section at such an early stage in the labor, with implications for future pregnancies, risks of classical cesarean and things like that. So, if they're going to have a planned cesarean section, the cesarean itself is probably going to be quite similar to a singleton cesarean section. However, there are differences if they are planning to deliver vaginally. So either if somebody comes in spontaneous preterm labor and the first twin is cephalic and you're going to aim for a vaginal birth, or if they come for an induction of labor, they should be delivering on the labor ward. So these are not suitable patients to be going to the birth center or having home births. They should be strongly advised to deliver on the labour ward because the pregnancies are and the labours can potentially be complicated. A lot of the time you need all hands on deck. You should scan the patient either when they're admitted in labour or for induction of labour to establish what is the presenting twin doing. You know, even if the most recent scan has told you that the twin that's being labelled as twin 1 is cephalic, it's not impossible that sometimes the other baby can end up coming first, which can be a problem if that second twin is not in a cephalic presentation. We should be monitoring both babies throughout the labour process, and you need to make sure that they're being monitored separately. So you can either use a FSE, a fetal scalp electrode, on the baby's head for the first baby, and abdominal monitoring for the second baby. You can scan to make sure that you're monitoring both babies separately abdominally. And it is possible to split the CTG trace as well. So normally the midwives are quite good at doing this. They can add 20 beats onto one of the twins to make sure that you can see both traces clearly. Although if they do that, you need to remember that one twin has had an extra 20 beats added, so the real baseline is 20 beats below what the CTG is telling you. You should make sure the patients have IV access and they've got a valid group and save, or if they're particularly at high risk of PPH, you might want to cross-match them. You need to consider the place of birth. You can either deliver it will depend a little bit on what the setup of your delivery suite is like and what the kind of culture of the unit is, but you need to make sure that you've got an appropriately sized delivery room. Babies may well need resuscitation, so you'll need 2 resuscitators, potentially 2 paediatric teams. And a lot of the time it might just be easier and more sensible to go to the operating theatre where there's often a little bit more space there. And then at least you're in the right place if there are any complications. In terms of analgesia, it's a good idea for these folk to consider having an epidural. It might make it more comfortable for them, especially if we need to do extra manoeuvres to deliver the second baby. If there are any complications with their attempted vaginal birth, or if the first baby comes out and second baby starts misbehaving, at least they've got analgesia on board and there won't be any delays with getting the baby delivered by cesarean if necessary. After the first twin is delivered, then you'll need to assess the position of the second baby with the scan. So you should make sure that you've got the scan with you, either in the operating theatre or the delivery room, wherever they're delivering. Stabilise the lie. So assess what position the baby's in, try and stabilise it as much as possible, particularly if it's in a longitudinal lie, which normally involves having somebody pressing on the maternal abdomen. Doing an internal examination to assess where's the station of the presenting part, and that for MCDA, DCDA twins, both babies will have their own amniotic sacs. So you'll most likely need to rupture the second sac once the first baby has delivered. It's quite common that the contractions can slow down or stop after the first baby has come out, so many patients will need oxytocin to get them contracting again. You need to make sure that you're monitoring the second baby closely throughout. So you need to make sure the CTG is good pickup, and the mode of delivery will really depend on the presentation of the baby. If the baby's in a head down position, then they should hopefully deliver normally, but you might need to do a breech extraction if the second twin is breech, or an internal pedalic version if the baby is transverse. So that's when you reach in and grab the baby's feet and sort of bring it down and deliver it breech. And ideally you should aim to deliver the second baby within 30 minutes of the first baby coming out. And then just, of course, being mindful of the risk of PPH. The womb has been more distended. There's 2 placentas inside you, so once the babies have delivered, you want to actively manage the 3rd stage, give either syntocinon or synthometrin, and aim to deliver the placentas as quickly as it's safe to do so. Consider using additional uterotonics if needed. Okay, so that's quite a kind of quick run through of multiple pregnancies. Does anybody have any questions? So I can see Ebbs has put a question in the chat box. After what duration of time would you need to repeat steroids of multiple episodes So it's normally, I mean, it's a sort of individualized decision. You can repeat them after 6 weeks, but ideally you would want to, I mean, it really kind of depends on what stage they're at in the pregnancy. And, you know, in an ideal world, we don't want to give too many courses. So if possible, it's better to kind of target the steroids when delivery is most likely. Not always possible, and it is possible to give them again after 6 weeks. Yes, Despoina.
Yes, hi, thank you. On the topic of steroids again, is the dose the same as in single-tip pregnancies in multiple pregnancies, or do we need to make any adjustments for that when giving?
No, we normally give the same dose. Joe?
I was just wondering, the 30 minutes thing between the first and second twin, are there specific reasons or thoughts behind that? What's the logic to the 30 minutes number?
So I mean, when I was preparing for this presentation, I actually couldn't see it documented anywhere in the NICE guidelines. It's something that's kind of traditionally been done to kind of aim to get both babies delivered fairly quickly. Nothing terrible will happen if you do happen to go over the 30 minutes. I guess you would be a bit concerned that, you know, why is it taking this long? Is there an obstruction to delivery? Is there going to be a problem? And that's probably a bit more likely if there's a larger inter-delivery interval. Traditionally, we try, that's just what we've kind of always aimed to do, although I was a bit surprised to see that I couldn't actually find it documented anywhere. So it's not, you know, sort of set in stone or anything like that. But I guess you just want to make sure that both, you know, because this woman is fully dilated, she's just delivered a baby, so you know, you would expect that there shouldn't be any difficulties in delivering the second baby, and if it's taking more than 30 minutes, is there something going on? I guess you need to ask yourself.
Cool, thank you.
Yes, Josh.
I was just wondering, for the second twin, if you're trying to do an internal pedalic version, at what point do you break the waters of that second twin? I presume it wouldn't be immediate. Would you want to at least graft something and then break it while you're bringing it down, or?
Yeah, I mean, ideally you don't really want to break the waters when, you know, without having something in the pelvis, because there's an increased risk of cord prolapse. So what you can often do is grasp hold of the feet through the, you know, through the amniotic membranes. And a lot of the time they will actually break themselves as you come down. But as with doing any sort of ARM, you want to make sure that whatever is presenting is within the pelvic, you know, it's in the vagina basically. You wouldn't do an ARM on a head at -4, so it would be the same really with you know, with the internal pedalic version. Most of the time they'll actually break themselves as you're bringing the baby, or as the baby comes down into the vagina. Anybody else?
I remember one time someone mentioned that at some specialist centres, you can have a twin that's born early and they might leave the other twin inside and it's born at a later time. Does that actually happen, or is it just a hearsay thing though? I
mean, it's not something I've ever come across myself. I'm sure there are sort of case reports of that happening. Normally, if you go into labour, you know, once the cervix has opened up, the second baby would end up coming out. I guess if the second baby didn't deliver naturally, and you were at a very early gestation, or if you're at a pre-viable gestation and everything is fine, then you know, there's no reason, and you know, mum's healthy, the baby inside seems to be fine, then you know, there isn't really a reason to say, well, let's get the other baby out just because the first baby is delivered. But it would need to be a sort of individualized decision, you know, with senior input, because there would obviously be risks as well once the first baby has come out.
Thank you.
Ms. Gowdy, just thinking about the second twin, why is it always internal pedalic version? Is there not a role for ECV?
Yeah, no, you could do ECV as well. So yeah, sorry, I should have really said that. So once you've delivered the second baby, and you assess the position of once you've delivered the first baby and assess the position of the second baby, you know, you can either try and do an ECV to get the baby to be in a head down position. it will probably depend on how relaxed the mum is. Another good reason to have an epidural on board and what the skill set is on the labour ward at the time. So yeah, if you are able to do an ECV, it is possible to, and you can get the baby in a cephalic presentation, then so much the better. If it doesn't work, or if it's not sort of considered to be suitable, obviously it will depend on the baby as well. If you had an abnormal CTG, you might be a bit cautious about sort of pushing a stressed out baby around too much.
Thank you.
Anything else?